Okay, so we're going to go ahead and get started. Today we are reviewing for lecture exam 3. Okay. So the chapters covered on lecture exam 3 are 8 and 9. Chapter 8 is joints, and then 9 is muscles and muscle tissue. Once we get past this unit, chapter 10 is all muscles, and that will be in the lab. So this is strictly for lecture. So going through chapter 8, it's not too difficult. It's a lot of memorization. So chapter 8 is joints and articulations. So joints, what is the name of a site where 2 or more bones meet? Anybody know? That's going to be an articulation. So when you hear a specific bone articulates with another bone, that's what we're talking about. And then the function of joints is to provide the skeleton with mobility, hold it together, and to protect it. So besides the hyoid, every bone forms a joint. Again, and that's why the hyoid is called like the free-floating bone, because that one does not articulate with any other bone. So specifically with joints, we have 2 types. We have functional and structural. Functional, this is where the acronym SAD comes in, if some of your professors have talked about it. These are the 3 types of functional joints. So synarthrotic, amphiarthrotic, and diarthrotic. Synarthrotic, these are classified as immovable or stuck. So synarthrotic, stuck. Amphiarthrotic, these are slightly movable. And then the diarthrotic are freely movable. And then for structural, we also have 3 types. We have fibrous joints, cartilaginous joints, and then synovial joints. So you want to be familiar with the different classifications of joints and then like the terms that fall underneath each of those. So fibrous joints, these are bones joined by dense fibrous connective tissue, and most of these are synarthrotic, which would mean immovable. So then with the fibrous joints, we have 3 types of those. Those are the sutures, syndesmosis, and the gomphosis. So remember the sutures, these are like the sutures of your skull that eventually fuse. Once they fuse together, they are stuck. And then like the gomphoses, your teeth in the sockets, those are usually pretty stuck unless there is some sort of trauma that occurs. And then we have cartilaginous joints. These are bones united by cartilage. These are not highly movable, cartilaginous joints, but they are slightly movable. So these would be amphiarthrotic. And then we have 2 types of the cartilaginous joints. These are synchondrosis and the symphyses. So we have like our pubic symphyses that we find in between the 2 oscocks. The symphyses are bones that are separated by a pad of fibrocartilage. So again, cartilaginous joints, fibrocartilage. And then the synchondrosis are hyaline cartilage between bone segments. So if we remember our ribs, they connect to our sternum via the hyaline cartilage. So that would be this right here.
So for the knee, it would only be like the fibrocartilage?
For the like femur and tibia, or what part? Just the knee joint in general?
For where the base is, like in the
That's a good question. And you said it would be fibrocartilage? That would say, yeah. No, this one is going to be hyaline cartilage. Okay, and then lastly, we have for structural, we have synovial joints. These are bones separated by a fluid-filled cavity, and all of these are diarthrotic, which mean freely movable. And then these have 6 distinguishing features with them. So we have articular cartilage, the joint cavity, articular capsule, synovial fluid, ligaments, and then nerves and blood vessels. There's a specific image that goes with this, these features. That is more lab though. Some examples of the synovial joints are your knee, elbow, shoulder, and hip. So some of the more common joints that we hear and learn about.
What is the name of the thyroid to
Mhm.
that one? Is that like referring to a specific type of joint?
No, just overall, it would be a joint or an articulation. Yeah. So overall, where 2 or more bones meet is a joint. Okay, and then a little bit more to synovial joints. We have bursae, which are sacs lined with synovial membrane that contain the synovial fluid. The bursae act to reduce friction where ligaments, muscles, skin tendons, or bones rub together. And then we also have the tendon sheaths, which are elongated bursae wrapped completely around a tendon subjected to friction. This is what I am talking about here. So if you can see it, this is where we have that bursae with the tendon sheath here. So this is your humerus articulating with your scapula, because we have the acromion of our scapula here. This top one is that subacromial bursae. I'm not entirely sure if you would have to know the specific name of the bursae or just that that's what it is. But here again is that joint cavity with the synovial fluid. We have the articular cartilage, and then we have that tendon sheath here. So these are working to lessen the friction around the bones. So we can see here, our humerus would be moving this way, and the humerus head rolls medially as the arm abducts, so taking it away from the body. And that's just lessening the friction, allowing that to not hurt you as you're doing it, and just allowing for like smoother movement. Let's see what else you need to know from here. I think that's kind of it. You just need to be familiar with bursae and tendon. And then another thing that is on here that's not on the PowerPoint is the menisci. So these are fibrocartilage pads that extend from the articular capsule. The menisci guide bones for a better fit. Okay, and then we have movement of synovial joints. So all muscles attached to bone or connective tissue at no fewer than 2 points. So this is where we get that origin and insertion. So the origin is going to be an attachment to an immovable bone or the less movable bone. So origin attachment to the immovable bone, and the insertion is the attachment to the movable bone. The muscle contraction causes insertion. So again, that movable point to move toward the origin. And then the movements occur along the transverse, frontal, or sagittal planes. And I think I have, yes, an example here. If you can see it, we have our origins here, which again is that the less immovable bone, and then our insertion down here. And this would be your bicep brachii. So on the lecture exam specifically, it might ask you like it may give you a specific muscle and then ask you to identify its origin or its insertion. So for example, if on your lecture exam, they tell you the bicep brachii has 2, let's say, points of origin, identify 2 of them and they give you a list of 4 bones, you would have to select 2 of those bones or something similar like that. So being able to identify the difference between origin and insertions. And then we get into range of motion. So we have different types of range of motion that refer to different types of synovial joints. So we have, they're all called axial. So as long as you remember axial and then you can remember the first part, you should be okay because it's pretty self-explanatory. Non-axial, these are slipping movements. Uniaxial is a movement in one plane. So an example of these are hinge and pivot, which we'll get into. Biaxial, movement in 2 planes, saddle or ellipsoidal. And then multiaxial are movements in or around 3 planes. These are ball and socket or gliding. And then we didn't touch on these fully. Do I have a picture? Yes, I do. We'll get to those, but you are also going to want to be familiar with flexion, extension, hyperextension, abduction, adduction, circumduction, rotation, lateral rotation, medial rotation. These are just the movements that occur with joints and muscles. And then we also have special movements that pertain to specific bones or joints. So supination and pronation of the radius and ulna. I can see that being a question on the lecture exam. Dorsiflexion and plantar flexion of the foot, inversion and eversion of the foot, protraction and retraction. The way that I usually see this is, I believe, the mandible. And then elevation and depression of the mandible as well, and then opposition of thumb. So just making sure you're familiar with each of these, what the movement looks like, or being able to describe the movement. And then we get into the types of synovial joints. So we have plane, hinge, pivot, condylar, saddle, and ball and socket. So plane joints, these are articular fat surfaces and they glide past. So some examples of these are between your tarsals and carpal bones. And then we have hinge joints. These are a convex projection that fit into a concave surface. So an example of this is the elbow, the ulna fitting into the humerus, and then also your knee. The pivot joint is a rounded projection that fits into the sleeve or ring of bone and allows for rotation. So I think the easiest example of this is your atlas and axis. The axis has that Dens process that projects up, allowing for rotation. A condylar or condyloid joint is an oval surface of one bone fitting into the cavity of another. The easiest example of this is your knuckle. So that's called the metacarpophalangeal bone or joint. And then saddle joints, each bone has both concave and convex surfaces. The big example of this is your thumb. And then ball and socket is usually asked about on both lecture and lab just because it's one of the bigger joints. So that's your shoulder and your pelvis and your femur. So the femur head going into the acetabulum and the humeral head sitting in the glenoid fossa. Okay, and then again, you'll want to know the different types of joints as well as the type of movement that each joint has. So there's an example here. Again, pivot, that atlas and axis, the saddle joints in your carpals, the plane joint where your tibia meets your, talus. So in your ankle. Hinge joint, like a door hinge, right, allows to be bent in this point. So your, ulna and humerus. The condyloid joint, and then ball and socket. So we do have 5 main synovial joints that we talk about in class. We have our jaw, or TMJ, that's the temporomandibular joint. Your shoulders, also called the glenohumeral joint or humeral joint. And then elbow, hip, and knee. So your jaw, or TMJ, has 2 types of movements. It has a hinge and gliding. And so hinge would be depression and elevation of mandible. And then gliding would be side to side or grinding of your teeth. Another thing to know that was mentioned in class is that this is the most easily dislocated joint in body. So that may also come up as a question on the exam. And then our shoulder, again, that's a ball and socket joint. This is the most freely moving joint in your body. And because of this, stability is sacrificed. So due to it being freely moving, you can do a lot of motion with it. It is sacrificing the stability of the joint. Okay, and then we have our elbow joint. This is the articulation of the radius and ulna with the humerus. This is a hinge joint, allows for flexion and extension only. So make sure you know that about the elbow joint. There are 2 ligaments that restrict the side-to-side movement of this specific joint. That's the ulnar collateral ligament and then the radial collateral ligament. I'm not too sure if you'll have to know this for the lecture exam, but it doesn't hurt to know. And then our hip joint, that's where our head of femur articulates with the acetabulum. This is a ball and socket joint, provides good range of motion, but is limited by the deep socket. Due to this specific joint, that is why we have the ability to be bipedal or walk on 2 feet. And then we have our knee joint. This is 3 joints surrounded by a single joint cavity. So we have the femoropatellar joint. If you're seeing these words on your exam and you're like, I have no idea what these mean, just break up the word. So femoral, femur, patellar, the patella, your kneecap, femoropatellar joint. And then we have the lateral and medial tibiofemoral joints, so tibia and femur. Our knee joint is our largest, most complex joint of the body. The knee capsule is reinforced by muscle tendons and ligaments stabilizing, oh my goodness, the knee joints include the capsular and extracapsular ligaments. These help prevent hyperextension of knee. We have the fibular and tibial collateral ligaments, the oblique popliteal ligaments, and the acromion popliteal ligaments. And then our intracapsular ligaments are our ACL and PCL. So the anterior cruciate ligament and then posterior. And then another thing to note is that knee joint injuries are vulnerable to horizontal blows. I can see that being asked on the exam. So that could either be like what type of joints are vulnerable to horizontal blows. That'd be the knee joint, or knee joints are vulnerable to what type of blows. Okay, and that does it for chapter 8. Some other things to know would be like the what are they called? Conditions that come with the joints. So we have bursitis, which is inflammation of the bursa, like we talked about. Tendinitis, inflammation of the tendon sheets. Arthritis, and then we can get even deeper into like osteoarthritis or rheumatoid arthritis. So I would just know some of those. I don't know what the essay question looks like for this specific exam, but it usually has something to do with the conditions that arise from. Did he send it out? Okay. Was it something having to do with? Okay. Yeah, if you have it so I can read it or look at it real quick. Sorry. Okay, so anaerobic respiration. And then what was that first one? Do you know?
I was like, I'm gonna work on
Oh,
this
okay.
one.
So being prepared to talk about anaerobic versus aerobic respiration. We can come back to that. Okay, so muscle tissue. Muscle tissue transforms chemical energy, so ATP to directed mechanical energy, or it exerts force. So we do have our 3 types of muscle tissue that we learned in the beginning of the semester. That's skeletal, cardiac, and smooth. Again, make sure you know those. That's just going back to the basics. Whenever you see the prefixes myo, mys, or sarco, those are prefixes for or regarding muscle. So anytime you see these 3 here, you know that it has to be dealing with muscle. And then some characteristics of muscle tissues that you are going to want to know and have to know the definition. We have the 3 E's and a C. So excitability, this is the ability to receive and respond to stimuli. Contractility, which is the ability to shorten forcibly when stimulated. Extensibility, ability to be stretched. And then elasticity, which is the ability to recoil to resting length. So again, you are going to want to know these 4. This can show up in the like a matching question, or just having to identify which word belongs to which definition. Okay, and then we get into some of the anatomy. So we have connective tissue sheaths of skeletal muscle, which an image will pop up in a bit. This supports the cells and reinforces whole muscle. And then if we're moving externally to internal, we've seen this before. We have epi, peri, and endo, and then mysium. So again, mys, that MYS is referring to muscle. I would know how to label it, which it will show up in a second, and then also what type of connective tissue is in each of the layers. So first we have epimysium. This is dense, irregular connective tissue that surrounds the entire muscle. Perimysium, this is the fibrous connective tissue surrounding the fascicles. And then endomysium, which is the fine areolar connective tissue surrounding each muscle fiber. And we can see it here. So again, we have our epimysium, perimysium, and then our endomysium. Let's see. Another thing to know would be, right, like our tendon. So knowing that tendons connect muscle to bone, and then ligaments connect bone to bone. That's another thing to know. But when we're talking about muscle, tendons connecting muscle to bone, which right here would be our femur. Tendons, these are tough collagen fibers. And then another definition to know would be aponeurosis. These are fibrous or membranous sheets connecting a muscle and the part that it moves. So an example of this is the epicranial aponeurosis. This is epicranial, we were talking earlier. So making sure you know those definitions and then how to identify them. Okay, and then there's specific characteristics of muscle tissue, and you need to know each of them for each of the 3 types. So skeletal, cardiac, and smooth. And an example of this would be which type of muscle is classified as voluntary. And then we just go to our chart, and that would be skeletal. Or it can also be asked, like, which of the 3 muscle tissues are classified, or of the 3 muscle tissues, which are classified as involuntary, cardiac, and smooth. So you just need to understand the difference between the three. The general characteristics, functions, and physiology. Another thing would be, right, like the gap junctions are not present in skeletal. They're sometimes present in smooth, but they are present in the cardiac. And then another thing to know would be, right, excited by nervous system, that would be the skeletal. The nervous system excites or inhibits for cardiac muscle. And then smooth, again, nervous system excites or inhibits. This specific chart is in the notes. If you don't have access to those, you can email me and I can send them to you, but this is available in the notes. And then we start talking about muscle attachments. So most muscles span joints and are attached to bones in at least 2 places. So it has to have an origin and insertion, but there can be several, or I'm sorry, a few origins or insertions. So again, insertion is the muscle attachment on the movable bone, and origin is the muscle attachment on the immovable bone or less movable bone. So an example, the deltoid muscle's origin is the clavicle or scapula. So it kind of depends on your professor. If you just said scapula, that would warrant full credit for some professors, but some other professors might want you to write acromion or spine. I know Mr. Torres specifically, if you just wrote scapula, that would be fine. So again, the deltoid muscle's origin is the clavicle and then part of the scapula. Its insertion is the deltoid tuberosity of the humerus. And then the deltoid is the primer mover of the arm. And that would be abduction. And that would be its action. We didn't talk about action too much, but that is also something you would need to know. The action is what, or the movement that the muscle is performing or doing. And then we also have direct and indirect attachments. A direct attachment is usually fleshly. This occurs when the epimysium of the muscle is fused to the periosteum of bone or the perichondrium of cartilage. And then the indirect attachment occurs when the muscle's connective tissue extends beyond the muscle and includes tendons or flat extensions of connective tissue called the aponeurosis. Okay, and then we start getting into the microscopic anatomy of skeletal muscle. So you will need to know both of this for lab and lecture. Of course, the lecture part is going to be more wordy questions, whereas in the lab, you'll have to actually identify them. So looking at these images here, so the sarcolemma, we think of this as like the plasma membrane. And the sarcoplasm would be like the cytoplasm of a cell. So they have the same type of function. They're just working in different areas. So again, sarcolemma, we think of this as the plasma membrane. And then the sarcoplasm would be like the cytoplasm of the cell, which I don't think it's on there. We have the sarcoplasmic reticulum that acts, again, like the endoplasmic reticulum. These surround each myofibril, which are these straw-like structures here or here. And then those myofibrils are the contractile proteins consisting of the light and dark bands. Those myofibrils contain the sarcomeres. And then we have the orderly arrangement of actin and myosin myofilaments within the sarcomere. So we have our actin myofilaments. These are the thin filaments. kind of hard to see on the image, but these are in blue. These extend across the I band and partway in the A band here. And then the actin are also anchored to the Z discs. And then we have our thick filaments, which we call myosin. These extend the length of the A band and are connected at the M line. Okay, and then this is something I believe Mr. Torres kind of touched on in class, so I can also see this being asked on the lecture exam. One muscle is many muscle fascicles. One muscle fascicle is many muscle fibers. One muscle fiber is many myofibrils. And then one myofibril is many sarcomeres. So again, I can see this being asked like as a matching question or true or false, something like that. So for example, true or false, one muscle fascicle equals many muscle fibers, true. Okay, and then we begin to talk about the neuromuscular junction. There's a lot going on here, so I'm kind of going to go over some of the definitions. So the neuromuscular junction is where a branch of a motor neuron contacts a skeletal muscle fiber. And then so these are the components of a neuromuscular junction. The axon terminal is the end of the motor neuron axon. It forms neuromuscular junction with skeletal muscle. The synaptic vesicles are membrane-bound sacs within the synaptic bulb. These contain the neurotransmitters. The neurotransmitter acetylcholine, or ACH, is released upon skeletal muscle, and it activates depolarization, which is then followed by contraction. The synaptic cleft is the space between the synaptic bulb and the sarcolemma of the muscle cell. The nerve does not make physical contact with the muscle. The motor end plate is the specialized region of the muscle cell membrane that contains receptors that bind the ACH, or acetylcholine. And then we have our ACH receptors. These are membrane proteins of the sarcolemma that bind ACH. When the acetylcholine binds to these receptors, it activates opening of the sodium channels of sarcolemma, and then it rushes into the muscle, causing depolarization, again, followed by contraction. And then when we are on the topic of contraction, we have two main categories. We have isometric and isotonic. You are, again, going to want to know the definition for each of these and then the difference between the two. So isometric, this is no shortening. This is muscle tension increases but does not exceed the load. And then we have isotonic contraction. The muscle shortens because the muscle tension exceeds the load. Again, you're going to want to know the difference between the two. And then also with isotonic contraction, we have concentric and eccentric. So in concentric, the muscle shortens and does work. So when you pick up a book or kick a ball. And then eccentric, the muscle generates force as it lengthens. Both of these are equally important for coordination and purposeful movement. So back to isometric versus isotonic. Again, these are just some images that will help you kind of see what we were talking about there. Isometric over here, we have the muscle attached to weight that exceeds the muscle's peak tension developing capabilities. When stimulated, the tension increases to the muscle's peak tension developing capability, but the muscle does not shorten like it does in isotonic. So right here is the tension developing, but it is not shortening. It's staying that same size. Here on the right side, we have an example of isotonic contraction, specifically concentric. We have the muscle developing enough tension or force to lift it. But once the resistance is overcome, the muscle shortens and the tension remains constant for the rest of the contraction. So again, isometric, isotonic. And then lastly, we talk about muscle twitches. So this is something we got to in class, but we didn't get to talk about it too much. So a muscle twitch is the simplest contraction resulting from a muscle fiber response to a single action potential from the motor neuron. So we have the different phases of a muscle twitch. We have the latent period, the period of contraction, and then the period of relaxation. The muscle twitch is a response to a brief stimulus. So something is causing the muscle to twitch. This is during the latent period occurs when the nerve fires and the events of excitation, contraction occur. During the latent period, there is no muscle response just yet. The period of contraction occurs when the cross bridges are active and the muscle shortens. And then the period of relaxation occurs when the calcium re-enters the sarcoplasmic reticulum. And then that force gradually declines to zero, like we can see here. So again, we have that latent period, the period of contraction, and then the period of relaxation. Again, I would know the definition for a muscle twitch and then the different what's occurring at each of these different phases. Okay, and that is all I have for you today. So this is again for lecture, but we do have lab reviews coming up next week on Tuesday and then also the following Monday. I also do have the practice lecture exams already here in the lab. If you are in one of the online courses, you can email me and I can email that to you. And then additionally, please utilize the PAC Anatomy Tutoring Program Canvas shell for preparation for both the lecture and lab exam. Many of the images that we have embedded in there, you will see on the exam. So please make sure you utilize that. If you have any questions, please email me. Also, if you have not, please put your banner ID in the Zoom chat. Thank you.